Hello, my name is Joel Moncur. I am from the Joint Pathology Center in Silver Spring, Maryland. Welcome to our series on using proficiency testing data to improve the performance of your molecular laboratory. Delighted to give you this talk on pre-analytical threats, in particular neoplastic cellularity, and why it's so important and cannot be ignored. These are my disclosures. So the bottom line up front for this talk is that PT data demonstrate that different methods of assessing neoplastic cellularity lead to different results. And the CAP Molecular Oncology Committee recently published an initial set of recommendations for standardizing neoplastic cellularity assessments. So we'll begin with a practical challenge here, which is that your molecular assay requires samples with at least 20% neoplastic cellularity. So based on this image, is this specimen adequate for testing? I'll give you a moment to look at it. So the short answer to that question is no, it's not. But before we discuss it, I'd like to give you a little bit of background. So the assessment of neoplastic cellularity is a key pre-analytical step in molecular oncology testing. It determines the percentage of neoplastic cells in a sample and thereby the specimen's adequacy for molecular testing. It's so important because it helps avoid false negative results due to insufficient tumor. And just as a very practical example, you may have a next-gen sequencing panel that requires samples with 20% or more neoplastic cells. If the sample has 50% neoplastic cells, then it is adequate for testing and can proceed with that assay. So the problem is that the assessment of neoplastic cellularity is imprecise. There was a prospective multi-institutional diagnostic trial performed by the CAP Molecular Oncology Committee to determine pathologist accuracy in estimating the percentage of malignant cells, and they found that there was low inter-observer precision. In fact, in half the cases, over 10% of the participants overestimated neoplastic cellularity, which again creates a risk for a false negative result that could connect a patient with a life-extending or life-saving therapy. So the CAP Molecular Oncology Committee conducted a questionnaire and a performance challenge to help explain why neoplastic cellularity can be imprecise. And the findings of that questionnaire revealed that laboratories are using a lot of interesting things, but one of the main ones was that laboratories are using different methods to assess neoplastic cellularity. And different methods lead to different results, not surprisingly. One of the important things is that laboratories were using different definitions for neoplastic cellularity. 70% were using the cell number method, where they were comparing the number of neoplastic cells compared to the overall number of cells. But 28% of labs were using the cell area method, where they estimated the area of neoplastic cells compared to the overall area of tissue. So if we come back to the image that I showed you, if I superimpose a little highlighting of the neoplastic cells, you can easily see that if we were to aggregate those and assess their area, if we were to aggregate the area involved by tumor, it would probably be around or a little bit greater than 20%. And that's different from the cell number method. And for this image, what I've done is I've superimposed an image or a dot over every single cell. And so for the neoplastic cells, there's a red dot. And for the non-neoplastic or benign cells, there's a green dot. And by counting all those cells, the neoplastic cellularity is actually 9.3% in this case. So what we found, again, in presenting this exact image to laboratories or participants of the Neoplastic Cellularity Proficiency Testing Program, was that labs that assess neoplastic cellularity by tumor area were more likely to overestimate the neoplastic cellularity. Here you can see in this plot that those that determine the cellularity by cell number had a lower response or lower estimation than those that determined the neoplastic cellularity by area, which had a higher estimate. So the reason that the right way to do this is to determine by cell number, and that's because the number of cells or nuclei in a sample directly correlates with DNA content. So laboratories should define neoplastic cellularity as the number of neoplastic cells or nuclei compared to the overall number of cells. So with that, I'm going to present you with another challenge image, which is that your molecular assay requires samples with at least 20% neoplastic cellularity. So based on this image, is this specimen adequate for testing? I'll give you a moment to look at it. So the short answer is no, it's not. Again, but before we go into that, I just wanted to share that laboratories, the reason why this image is problematic for some folks is that laboratories use different methods to assess tumors with in situ carcinoma. So hopefully you can appreciate that in this last image that there are myoepithelial cells that surround this pre-existing duct. And that all the neoplastic cells here are within existing ducts, so they're ductal carcinoma in situ. The only invasive part of the tumor is actually over here on the right side of the image. So if labs are assessing that differently, then again, they're going to get a different result. So we found that 73.7% of laboratories do not include in situ carcinoma in their estimations, whereas 17.5% do include in situ carcinoma in their estimations. And if we can look at a box and whisker plot here, you can see that those that do include in situ in their estimations got a much higher estimate than those that do not. Once again. Now, so this raises up a few points. One of them is that a pathologist should be the one that does these neoplastic cellularity assessments, and that is indeed a CAP accreditation requirement. And that's because really it's only pathologists that are adequately trained to recognize things that may be subtle in some instances, like in situ versus invasive carcinoma. And in general, laboratories should be very cautious about including in situ carcinoma in their estimations, and that's because mutations within in situ carcinoma may not always be concordant or conserved in the invasive component of the tumor. So for instance, HER2 can be amplified in situ carcinoma, but not in the invasive carcinoma. But conversely, PIK3CA mutations are oftentimes conserved between the in situ carcinoma and invasive carcinoma. So it's a little bit dependent upon the mutation that's being studied. So to address some of these variations in practice that we identified through the questionnaire, the CAP Molecular Oncology Committee published an initial set of recommendations to help laboratories standardize their assessments of neoplastic cellularity. And I'm not going to go through all of these, but I'll certainly highlight some that we touched on, which were that laboratories should define neoplastic cellularity as the number of neoplastic cells or nuclei compared to the overall or total number of cells or nuclei. And also, we touched on the fact that neoplastic cellularity assessments should be reviewed by a qualified pathologist. All this table and the other recommendations are included in the publications that's listed here, and is also present on the Molecular Oncology Topic Center, which I'll mention in a moment. So in conclusion, proficiency testing data demonstrate that different methods of assessing neoplastic cellularity lead to different results. And to help address this in standardized practice, the CAP Molecular Oncology Committee recently published an initial set of recommendations for standardizing neoplastic cellularity assessments. I'd like to take this opportunity to highlight that the CAP on its website has a Molecular Oncology Topic Center that lists the publication I referenced today, publications I referenced today, as well as all the other wonderful publications that highlight proficiency testing data that can help your laboratory improve its performance. Thank you very much and have a wonderful day.